Hello everyone, this is our presentation on the hip-hop case by myself, Lily Salcedo, and my partner, Wences Castillo. The bottom line up front: 4 process revisions, reducing the inter-arrival time to 70 minutes, adding an extra OR and pooling them, hiring 2 CRNAs and pooling them, and hiring 2 PAs and pooling them are recommended to reduce the average flow time for patients by about 22% in Track A and 24% in Track B, and to increase the number of surgeries completed each day to 7 surgeries per track. The current operations at Hipkins Hospital operate as a combination of a batch process and a job shop. In this case, the batch processing is connected to the 2 staff members who are in charge of registering the patients in both OR groups. The slight flexibility in this process makes this registration process a batch process because of the degree of variety and customization that is less than that of a job shop, and because the registrar deploys a general purpose equipment. However, other processes at Hipkins Hospital operate as a job shop, such as the surgeons performing their duties as well as the CRNAs and PAs. While the equipment in the job shop may also be of general purpose nature, the workers are highly skilled medical professionals and the work itself is highly customized and highly engineered. The base case, which is depicted on this slide in Figure 1, illustrates both tracks A and B as having an inter-arrival time of 90 minutes, a surgery mean time of 100.71 minutes, and a surgery standard deviation time of 8.09. Further, the base case employs 1 anesthesiologist per track, 1 surgeon per track, and 2 ORs per track. To assess the variability in this base case scenario, we ran the AnyLogic simulation 5 times in order to compare mean flow times and surgeries completed. Our findings are depicted in this slide on Figure 2. Figure 2 depicts that the sample mean of flow times for the 5 scenario runs for Track A averages to be about 194.67 minutes, while the standard deviation is calculated to be 5.37. In these 5 runs, Track A was able to complete 4 surgeries 2 days in a row and 5 surgeries 3 days in a row. For Track B, the results varied slightly as the sample mean of flow times for the 5 scenario runs averaged to about 206.4 minutes, while the standard deviation was calculated to be about 10.79. During these 5 runs, Track B was able to complete 5 surgeries the first day, 4 surgeries on days 2 and 3, 5 surgeries on day 4, and 4 surgeries on day 5. Figure 3 on this slide depicts one of the AnyLogic runs in the base case. As is demonstrated in this figure, the main bottlenecks result from the ORs, followed by the anesthesiologists and the surgeons. The bottlenecks affect the number of surgeries that are able to be completed in one day because they decrease efficiency and cause longer waiting times. For example, the slower the patients are processed into the OR, the longer they have to wait to begin their surgery. Coupled with the fact that patients arrive steadily every 90 minutes, waiting times become even longer and fewer surgeries are able to be completed. This has caused much frustration and anxiety among patients and their families. And it has also burned out the surgeons and anesthesiologists who work tirelessly to complete as many surgeries as they can in one day. To address some of these bottlenecks depicted in the base case and increase the number of surgeries able to be completed on each track, we recommend reducing the inter-arrival time of patients to 70 minutes in both tracks A and B, adding an OR and pooling them, hiring 2 CRNAs and pooling them, and hiring 2 PAs and pooling them as well. We also recommend keeping 1 anesthesiologist per track, 1 surgeon per track, and keeping the mean and standard deviation the same as the base case. Going back to our original discussion on batch processes and job shops, it is imperative to pool services where we can and minimize the amount of highly customized processes that take place in the hospital in order to minimize the flow time of patients, which will in turn maximize the number of surgeries able to be completed in one day. Our text, Business Process Analysis, states we generally get better overall performance if we pool the servers and have them serve a single line of flow units. The use of pooling techniques in the optimal case enables processes to move toward more of a batch process style and keeps the surgeons operating on a job shop style. Even more, we are recommending that with these improvements, the hospital will be able to reduce the inter-arrival time of patients to 70 minutes per track, which will help to boost efficiency. The optimal case, depicted on this slide in Figure 4, illustrates tracks A and B as having an inter-arrival time of 70 minutes, a surgery mean time of 100.71 minutes, and a surgery standard deviation of 8.09. As mentioned, the optimal case employs 1 anesthesiologist per track, 1 surgeon per track, 5 ORs pooled, 2 CRNAs pooled, and 2 PAs pooled. To assess the variability in the optimal scenario, we ran the AnyLogic simulation 5 times in order to compare mean flow times and surgeries completed. Our findings are depicted in Figure 5 on this slide. Figure 5 illustrates that the sample mean of flow times for the 5 scenario runs for Track A averages 151.43 minutes, while the standard deviation is 7.58. In these 5 runs, Track A was able to complete 7 surgeries on all 5 days. For track B, the results varied slightly as the sample mean of flow times for the 5 scenarios averaged 157.34 minutes, while the standard deviation was calculated to be about 7. During these 5 runs, track B was also able to complete 7 surgeries on all 5 days. As a result, flow times in track A decreased about 22% from 194.67 minutes in the base case to 151.43 minutes in the optimal case. Similarly, track B flow times decreased by 24% from 206.4 minutes in the base case to 157.34 minutes in the optimal case. Also, as a result of the process changes, surgeries increased from about 4 to 5 surgeries per day in the base case to consistently 7 surgeries per day in the optimal case. The reduction in flow times for tracks A and B shows that pooling does matter. The pooled ORs, CRNAs, and PAs are able to better accommodate variability in their service requests, which helps to reduce bottlenecks. For example, if one patient takes longer to process or one patient's surgery takes longer to finish due to complications, the other pool members can keep the line moving in their parts. They are also able to help optimize the other track. Pooling these services also enables an increased number of surgeries to be completed per day and per track, which helps maximize the efficiency of the hospital and the utilization of surgeons. Resource utilization is maximized by pooling the 5 ORs and the 2 CRNAs and PAs, reducing idle time and ensuring that critical bottlenecks are addressed efficiently. The pooling strategy aligns with findings that pooling resources improves throughput by smoothing variations in demand. Utilization also matters in this case as well. In the base case, bottlenecks occurred as a result of inefficiencies in the ORs, leading to surgeons and anesthesiologists being overutilized and worked tirelessly. The addition of another pooled OR room helped to increase utilization in this area, which helped to decrease bottlenecks. However, with the process improvement came the realization that the surgeons and anesthesiologists needed a few extra pairs of hands to help wrap up surgeries so that they could begin on the next patient. Therefore, adding 2 CRNAs and 2 PAs helped to smooth out the utilization curve and keep operations running smoothly without adding bottlenecks. The confidence interval for the base case is shown in Figure 6. At the 95% confidence level, flow time would be between 189.96 minutes and 199.38 minutes for patients on Track A. For Track B at the 95% confidence level, patients would be waiting even longer with a flow time between 196.94 minutes and 215.85 minutes. The confidence interval for the optimal case is shown in Figure 7. At the 95% confidence level, flow time will now be between 144.79 to 158.07 minutes for Track A and 151.2 to 163.47 minutes for Track B. The decrease in the flow time not only decreases the amount of time that patients will have to wait to be operated on, but it also increases the number of surgeries that can be performed in one day. An increased number of surgeries able to be completed in one day decreases the likelihood that patients will be rescheduled for operation on the following day due to backlogs and inefficiencies. Psychology matters in this case, as pooling ORs, CRNAs, and PAs can drastically reduce patient flow time, while an increased number of surgeries performed in one day shortens patients' perceived wait time. This is possible because when patients sit in the waiting room and see other patients being processed and operated on quicker, their perceived wait time decreases with the anticipation that their time for surgery is coming soon. Further, using the confidence interval, doctors can give their patients an estimate of their waiting time. According to an article written by Kairos Health, transparency about wait times can go a long way in tempering patients' expectations. Research has shown that 80% of patients would be less frustrated if they knew how long the wait would be. This transparency from doctors in shortening perceived wait time can help alleviate any stress or anxiety the patient and their families may be feeling, which helps to improve their overall well-being. The confidence interval for the base case is shown in Figure 6. At the 95% confidence level, flow time would be between 189.96 minutes and 199.38 minutes for patients on Track A. For Track B at the 95% confidence level, patients would be waiting even longer with a flow time between 196.94 minutes and 215.85 minutes. The confidence interval for the optimal case is shown in Figure 7. At the 95% confidence level, flow time will now be between 144.79 to 158.07 minutes for Track A and 151.2 to 163.47 minutes for Track B. The decrease in the flow time not only decreases the amount of time that patients will have to wait to be operated on, but it also increases the number of surgeries that can be performed in one day. An increased number of surgeries able to be completed in one day decreases the likelihood that patients will be rescheduled for operation on the following day due to backlogs and inefficiencies. Psychology matters in this case, as pooling ORs, CRNAs, and PAs can drastically reduce patient flow time, while an increased number of surgeries performed in one day shortens patients' perceived wait time. This is possible because when patients sit in the waiting room and see other patients being processed and operated on quicker, their perceived wait time decreases with the anticipation that their time for surgery is coming soon. Further, using the confidence interval, doctors can give their patients an estimate of their waiting time. According to an article written by Kairos Health, Transparency about wait times can go a long way in tempering patients' expectations. Research has shown that 80% of patients would be less frustrated if they knew how long the wait would be. This transparency from doctors in shortening perceived wait time can help alleviate any stress or anxiety the patient and their families may be feeling, which helps to improve their overall well-being.
While splitting tracks A and B based on patient BMI might seem logical to some, we argue against this approach. It neither significantly enhances customer flow time nor increases the number of surgeries completed. It also raises ethical concerns. Figure 8 illustrates a scenario where track A is segregated from track B by patient BMI. In this setup, track A, which are patients who are considered underweight, have a mean flow time of 97.62 minutes with a standard deviation of 6.79 minutes. Track B patients who are considered overweight or obese have a mean flow time of 103.8 minutes with a standard deviation of 13.42 minutes. This model uses identical constraints to the optimal case discussed in previous slides. The data suggests that BMI-based splitting offers negligible operational benefits while posing ethical challenges. We ran the AnyLogic simulation 5 times to analyze the impact of splitting patients by BMI. Figure 9 shows that track A, with a mean flow time of 141.33 minutes, had a 6.6% decrease with a standard deviation of 5.14 minutes. Track B, with a mean flow time of 145.16 minutes, showed a 7.7% decrease with a standard deviation of 7.4 minutes. Both tracks completed 7 surgeries per day, which is identical to the recommended scenario. Although BMI-based splitting reduced flow time slightly, it did not increase the number of surgeries performed. Additionally, splitting patients by BMI is unethical and conflicts with our commitment to diversity, equity, and inclusion. According to the National Library of Medicine, stigma impacts care quality for patients with obesity. We analyzed 2 scenarios reducing surgical procedure variance by 10% and 20%. Comparing them both to the baseline results. For the baseline results, track A had a mean flow time of 151.43 minutes with a standard deviation of 7.58, while track B's mean was 157.34 minutes with a standard deviation of 7 minutes. The key findings with a 10% variance reduction showed that track A's flow time improved slightly to 149.86 minutes with lower variability at 2.66. Track B saw improved flow time at 145.74 minutes, though its variability increased slightly to 9.37. With a 20% variance reduction, track A's flow time reduced further to 147.11 minutes, but variability increased to 6.1, close to the baseline. Track B achieved the best results with a mean flow time of 143.52 minutes and the lowest variability of 3.5. In conclusion, reducing variance improves flow time and consistency, but the overall benefits of reducing variance in this case are negligible and not worth the investment it would take to make them. Next, we're going to perform a hypothetical cost analysis. First, on personnel cost, adding 2 CRNAs and 2 PAs will require an estimated annual investment of X number of dollars per CRNA and Y number of dollars per PA, bringing the total additional personnel cost to 2 times X plus 2 times Y. While this is a significant investment, it directly addresses critical bottlenecks, which will improve operational efficiency. We recommend pooling resources for operating room modifications. This approach will minimize the need for new infrastructure beyond the additional OR room. Next, let's consider the efficiency gains. By increasing surgeries from the current 4 to 5 per day to 7 surgeries per track, 14 in total, there's a substantial opportunity to generate additional revenue. With Z numbers of dollars earned per surgery, this increase represents a significant financial benefit. Additionally, reducing patient flow times enhances patient satisfaction, potentially boosting referrals and attracting more private practice patients. Implementation costs will include a one-time investment in training for staff for resource pooling, estimated at $8, and potential upgrades to scheduling systems, which would cost approximately B number of dollars. Taking these factors into account, the increased capacity of over 40% in daily surgeries positions the hospital for long-term financial growth. To conclude, our analysis identified 4 critical process revisions that can significantly enhance the operational efficiency at Hipkins Hospital. First, reducing the inter-arrival time to 70 minutes optimizes patient scheduling and reduced wait times. Second, pooling resources such as operating rooms, CRNAs, PAs creates greater flexibility and ensures better utilization of available staff and facilities. Third, the addition of 2 CRNAs and 2 PAs helps address the bottlenecks, allowing us to meet the growing demand for surgeries. As a result of these changes, we observed a reduction in average patient flow time of 22% for Track A and 24% for Track B, and an increase in the number of surgeries completed each day, achieving 7 surgeries per track. We recommend implementing these pooling strategies while keeping patient-centric scheduling as a priority. This will not only improve efficiency, but also reduce patient anxiety by minimizing wait times. Finally, regular monitoring of key performance indicators like surgery completion rates and patient flow times will be essential to sustaining these improvements over time. Thank you. Here's a list of our references.